It's really a pleasure today to introduce Dr. Nikolas Blevins as a professor of otolaryngology at Stanford University and director of the Stanford Cochlear Implant Center. Dr. Blevins' clinical interests include the treatment of hearing loss and tumors of the cranial base. His research is focused on the development and application of technology to augment microsurgical approaches to the skull base, which includes the use of computer modeling and immersive surgical simulation for education and preoperative planning. And additionally, he and his collaborators are developing minimally invasive techniques for inner ear microendoscopy, surgical microrobotics, and other technologies applicable to hearing restoration. Dr. Blevins, for those of you who have not met him already, is a California native and received his bachelor's degree from Stanford University. He completed his medical training at Harvard University before returning to California for his residency at UCSF. He remained at UCSF for a fellowship in otology neurotology and joined the Stanford Department of Otolaryngology in 2003. For full disclosure, I think as Sally mentioned, Dr. Blevins was my surgeon for my two cochlear implant surgeries, one in 2014, one in 2015, and was also Sally's surgeon for her CI implant. And finally, most of you know Matthew Fitzgerald, Dr. Fitzgerald, who's spoken to us at least 3 times, and he is a close colleague of Dr. Blevins. So, Dr. Blevins, thank you for joining us today. We're looking forward to your remarks.
Oh, thank you, Elliot. It is such a pleasure to be here and see some long-standing friends. So Sally and Elliot, I'm glad to see you still running things so well. It's always wonderful to see you and participate in these conferences. And I know how important the HLAA is and commend you for the work that you're doing with it. Let me share my screen.
Okay, let's see. Yeah, you've got it.
All right. Are you all able to see my slide?
Yes.
All right. So I think this is going to work. So hopefully my audio is coming through as well. I know how important that is. So as Elliot said, I'm Nick Blevins. I'm here at Stanford. I've been here for probably a little over 20 years now. And it's been a real honor for me to participate in hearing restoration management for our patients here. Today, I'll be talking about hearing restoration and sort of give an overview of the surgical approaches to restoring hearing. We'll talk about cochlear implants, but not exclusively, and we'll talk in more general terms about hearing and its mechanism and what can go wrong. So as Elliot said, I'm at the Stanford Ear Institute, which is a satellite clinic for the main department of otolaryngology. Stanford otolaryngology is, I don't know, can you see my mouse if I point with my mouse?
Yes. Well,
Okay.
Actually, no, I can, yeah, I think we see it.
Can you see it if I'm pointing?
Yes, now we can.
All right, great. So we're over here on the intersection of 101 and Embarcadero in Palo Alto. So anybody can come by and find us if you're interested. Let me go back here. All right. Some of the illustrations that I will be showing today come from the Stanford Otolaryngology, Otology, and Neurotology atlases, which were created by Dr. Jackler and Chris Graylap, the medical illustrators. So anyone who's interested in seeing more of these illustrations and getting a better idea about the anatomy that goes into the types of surgery that we do, take a look. It's all available free for educational purposes online. So let's talk a little bit about ear anatomy and how that can influence hearing. This is cut through the head like this, looking at the ear. Of course, we have the external ear, which everyone can see. Then there's the ear canal, which is a couple of centimeters lined by skin. And then after that, there's the middle ear, which is an air-containing space that contains the tympanic membrane and the three ossicles, the malleus, the incus, and then the stapes. And the stapes is up against the inner ear, which is comprised of the cochlea, or the organ of hearing, and the balance system, the semicircular canals, and the vestibule, which is the organ of hearing. Both of those are connected by nerves to the brain stem to carry information to our brains to give us a sense of hearing and balance. So normally sound vibrations come in through the ear canal, vibrate the tympanic membrane, vibrate the three ossicles, vibrates the fluid in the inner ear, and that's really where the nerve impulses are generated, converting the sound vibrations to an electrical impulse, and that then is carried through the nerves to the brain. So when we think about hearing loss, we can break it into two major categories. There's conductive hearing loss, which is really a mechanical problem, a difficulty in getting sound from the outside environment to the inner ear. And we differentiate that from what we call sensorineural hearing loss, which is a problem converting the sound to electrical energy, transmitting that electrical energy to the brain, or processing that electrical energy. And although we call it sensory neural hearing loss, very little of it is actually primarily a neural problem, a nerve problem. Usually the nerve is okay. Most of the cases of sensory hearing loss are just that. They're problems with the cochlea and not so much the nerves or the brain. And we'll talk more about the implication of that. So, of course, to understand everybody's level of hearing and hearing loss, you're all familiar with the audiogram. I'll just go through this briefly. The main chart that we see in an audiogram shows frequency on the x-axis and decibel levels, or loudness, on the y-axis. So the low tones are here in the low frequent in the left side, and the high squeaks are up here on the right side. Our hearing goes from about 120 hertz all the way up to about 20 kilohertz. All right, so there are really high frequencies that we can hear under the best of circumstances, but we can't measure them reliably. So really, clinical audiometry usually stops at about 8 kilohertz, which is still a high squeak compared to what we normally hear in speech. And then the decibel range goes from 0, which is the softest sound that a 18-year-old with, quote, normal hearing should be able to hear. My voice, or most of our voices under normal circumstances, are at about 50 decibels in this range. Jet engines are down here at 120, all right? And we can then separate the intensity at which people can hear sounds based on how loud we have to turn each of those frequencies up. And I'm very reluctant to make sweeping generalizations about hearing loss, whether it's mild, moderate, or severe, because there are a lot of nuances to that can really affect how somebody is behaving in daily activities. But if you'd like, we can break the mild range into 25 decibels to 40 decibels. 40 to 60 falls in that moderate category. 60 to 80 we consider severe, and then greater than that is really into the range of profound hearing loss. We also have to remember that part of the audiogram constitutes word recognition scores, which is your ability to understand words and not just your ability to hear sounds. So, of course, hearing a sound presented in a soundproof room is a fairly simple task when you compare that to understanding words in a restaurant or at a cocktail party. And we try to be more realistic in terms of the ability for individuals to process sound in addition to just hear the beeps. And we'll talk about the implications of that as well. And if you take the fundamental building blocks of speech in the English language and you were to graph them at normal conversational levels onto this graph, you'll see where these fall. This is sometimes referred to as the speech banana because of this little curve that it seems to make. But what's most important about this, and one thing I want everybody to take away, is that you'll see down here are all the consonants. I'm sorry, are all the vowels down here, which means those vowels are low and they're loud, right? So a lot of the energy of speech is presented by the vowels that are presented in low frequency range. Up here, we have the consonants, the Ks, the Ss, the Fs, and the THs. Those are high frequencies and they're soft compared to the volume of the vowels that we see. And the importance of that is that if you're missing the high frequencies, you're missing a lot of the information that is normally carried in speech. You can often hear people are talking because you can hear the vowels, but you can't hear the consonants, without which you really can't make sense of the words that are being presented. When we measure hearing levels, we can present the sound to the ear in a couple of different ways. The conventional way that we hear is through the air. And so we can take a speaker or a tuning fork and we can hold it next to the ear and we can vary the frequencies that are being presented and we graph them on the audiogram graph. So this would be somebody with normal hearing as the sound is perceived through what we call air conduction, because the sound is getting to the inner ear through the conventional way, going through the external ear, middle ear, to the inner ear, and being sent to the brain. So we consider that air conduction. Now, different from that is what we call bone conduction. And there is a way, if you take a tuning fork or a microphone or a speaker and you put it up against the bone behind the ear, the mastoid bone behind the ear, those vibrations can be directly transmitted to the cochlea without having to go through the ear canal, without having to go through the middle ear. So that in many ways is a more direct route to the inner ear that doesn't rely on the conduction, the mechanical conductive pathway of the ear. So we can graph those with different symbols onto our graph as well, and we call that the bone conduction line. In patients who have a conductive problem, a problem with the ear canal, the tympanic membrane, the middle ear, we see a gap between what you can hear through the bone and what you can hear through the air. And the difference between these marks is the hearing loss that's caused by the conductive component of hearing. This isn't always the case, but in the great majority, when we see this, it means that there's a mechanical issue. And I just put a representative word recognition score down here. So word recognition can be on a percentile scale or a percent scale from 0 to 100%. Anything above 90 and above is considered normal. People who have good inner ear function, as demonstrated by the bone line, but even a severe conductive hearing loss usually have good word recognition. So if you turn the sound up loud enough, the sound can be transmitted to the inner ear, which can process the sound appropriately and can provide useful information to the brain. So conductive hearing losses usually have normal word recognition scores. Contrary to that is the sensorineural hearing loss. And this is the type of hearing loss that most people with hearing difficulties experience. You'll notice the shape of the graph is different, right? It's more of a high frequency loss, which is more typical of people who have had injuries or damage to the inner ear. You'll notice the bone conduction falls right in line with the air conduction, meaning it's not a problem with getting the sound to the inner ear. It's a problem with the inner ear picking up the sounds and processing it. And in those individuals, the word recognition score also drops off, sometimes very abruptly, meaning that they're not able to understand the words even when those sounds are presented loud enough for them to hear them. Right? And this is a sound processing problem, which is different from audibility, which is just the ability to hear sounds. But it does play into that speech banana that I showed before, because this is the typical high frequency inner ear hearing loss. And somebody with this type of hearing loss, again, is just not going to be hearing those consonants that carry the great majority of the information in sound energy. So when we talk about problems with the ear and sort of surgical approaches to it, let's start by talking a little bit about conductive hearing loss. So again, it's a problem with the mechanics of getting the sound to the inner ear. That's where you'll see that air bone gap that we looked at earlier when we were looking at the audiograms. So crucial for that is an open ear canal, as is seen here, and an intact, normal appearing tympanic membrane, which is what we're seeing here. So this is what we see on otoscopy when we look with a microscope or we look with a handheld otoscope, or if you look with one of those little home endoscopes that you can get now online, this is what you'll see. So this is the tympanic membrane. This white area here is the long process of the malleus, right, which is the part of the ossicular chain that is attached to the tympanic membrane. So when sound comes in, it vibrates this sort of like a microphone cone, and that will vibrate the malleus and subsequently the bones that are kind of hidden back here behind the tympanic membrane to get the sound to the inner ear. One of the most common things that we see that causes conductive hearing loss is a problem with the eardrum or the middle ear. So this is not a healthy eardrum or not a healthy middle ear. This is somebody who's got a chronic otitis. It's probably somebody who's had many years of infections that have involved the middle ear space. And over time, those infections and the products of those infections can break down this thin tympanic membrane to a point where it's thick, it's scarred, and in many places it's missing. So this has about 60% or 75% of this eardrum is missing. So you can imagine an ear like this, the eardrum is just not going to vibrate in its normal way. This is the incus and the stapes here, which we normally don't see in a tympanic membrane. And you can see that there's probably a gap here between the two as well, indicative of a middle ear issue in addition to the tympanic membrane. We're pretty good at fixing these, right? We don't always get rid of the infections and we don't always close the holes, but small holes and even big holes, we can usually fix with a tympanoplasty, which is just a matter of surgically placing some tissue, right? It's either the tissue from the bump in front of the ear or the lining of the muscle behind the ear under the remnant of the tympanic membrane and putting that back so it's a scaffolding, it's a graft onto which the normal skin can then grow. And those probably take about 90% of the time. Now, what about if the middle ear bones aren't working? So this is a schematic of how the ossicles normally move. And again, this is a simplified version. And remember that the tympanic membrane and the ossicles move on almost an anatomic scale when sound hits it. So this is just an illustration of the amount of motion that we see. But if these bones are worn away, as often happens, and was probably the case in that patient that I showed you just in the last couple of slides, when these bones vibrate, this is not, and you're going to end up with that kind of loss. Well, there are prostheses that we can put in that reconstruct that ossicular chain and can be pretty effective as well. Again, it's not perfect, but we do pretty well with reconstructing the ossicular chain in many cases if we can control the underlying infection. This is my only surgical video. I hope everybody's okay with it. It's highly magnified, but I just wanted to show this because it gives you an idea about the scale that we're working at. This is in a patient who has otosclerosis, and this is after having done a stapedotomy, right, or a stapes surgery. And in people who have otosclerosis, it's an inner ear problem, but the bone that surrounds the inner ear grows up onto the stapes footplate and keeps it from moving, so that when the incus vibrates, the stapes no longer does. And we can replace the stapes with a little wire and a little piston, actually by putting a hole into the inner ear, so that when the incus vibrates, the fluid in the inner ear vibrates again, restoring that type of conductive hearing loss. And this is just after such a prosthesis has been placed. This is just to give you an idea about scale. This distance here, you see where the piston is, that's about 1/2 millimeter. All right, so we're working at very small scale, and you can see when I touch the incus, this little piston moves. And so we're very careful about not pushing it too much because we don't want to traumatize the inner ear when it's been open in this case. But we do really well in about 90% of these types of procedures as well. So another thing to remember about these conductive hearing losses, and we've talked about that, is that the bone line, the inner ear, is actually working really well. Can we take advantage, in some cases, of this inner ear, even if we can't take advantage of the middle ear? And that's not a new idea. The concept of bone conduction hearing devices has been around for hundreds of years now, right? And there were devices that you could purchase that you could put on your teeth that would help you hear external sounds. And if you go out to the technology store today or look online, there are bone conduction devices that are quite effective at getting sound to the inner ear without having to put anything in the ear canal itself. And that's great for people who are exercising and want to be able to have an open ear as well. There are certainly some patients in whom we cannot restore the external ear and the middle ear surgically. This is a patient who has a congenital malformation of his ear, right? So instead of trying to repair this, which was really just not possible from a surgical perspective, we did what's called a bone-anchored hearing aid, or a BAHA, and there are a number of these that are available, which requires putting a little pin into the bone and then attaching a hearing aid onto that will vibrate that pin and transmit the sounds directly to the inner ear. Now, for something like this to work, you still need to have an inner ear that's functional to receive those signals. So this is different from a cochlear implant. Although there are now also devices that are completely implantable with just the processor, an external processor, so the actual device is covered by skin. This one has to go through the skin. And this is certainly preferable because there are fewer skin side effects. And there are a couple. This is an Ossia device made by Cochlear. There's a bone bridge that's made by Med-El. So there are a number of these different types of devices available. All right, so let's switch gears and we'll talk about sensorineural hearing loss, which is on the other side of this equation, where we can get sound to the inner ear, but the inner ear isn't working. And again, the great majority of sensorineural problems are because the cochlea isn't working. All right, and let's just take an overview of the inner ear. The inner ear is the organ of hearing, which is 2.5 turns of the cochlea, the vestibule, which senses linear acceleration, and the 3 balance canals, all of which are at 90 degrees to each other, right, that sense angular acceleration. If we take the turns of the cochlea and we cut across them, this is what we would see. All right, so this is a cut through that snail shell shaped cochlea, right? Each of the turns, or the entirety of this tube that's coiled up, has 3 components. There's the scala tympani, the scala media, and the scala vestibuli, right? And the chemical composition of the fluids within those spaces is different. And that actually provides the energy for the inner ear to work. And these membranes are really thin. So when sound comes in, it vibrates the stapes. The stapes is connected to the scala vestibuli, all right, and it transmits that vibration up the 2.5 turns to where these two components are actually connected. And then the vibration comes back down the 2.5 turns in the scala tympani, and it moves the round window, which is another membrane that sits here, which is really a membranous connection between the inner ear and the middle ear that offsets the motion of the stapes, right? So that vibration is transmitted to these membranes in the inner ear, which then vibrate up and down and let the inner ear know that sound is coming in. And it's here on the basilar membrane that the actual organ of hearing is located. This is where we have the hair cells, which are microscopic cells that have little tiny hairs on them. And when those hairs are deflected, these hair cells stimulate the nerves that extend from the core of the cochlea out to this organ of Corti, the organ of hearing. All right, so we have 3 rows of outer hair cells, 1 row of inner hair cells, and it's all located on what's called the basilar membrane, which sits between the scala media and the scala tympani. So this is really where the magic happens in terms of hearing, because it's taking those sound vibrations and it's turning it into an electrical signal. And there's a lot of sound processing that actually occurs here in the inner ear. The inner ear is not just a passive receiver for sound energy. These hairs, the hairs on the hair cells are actually embedded in another little membrane. And they can actually contract or extend in real time to mute and to attenuate other sounds that are coming in. So when we try to listen to one person in the presence of background noise, our inner ears are helping us by tuning into and accentuating the frequencies that we're most paying attention to and excluding those that are distracting. And this is why when you have injuries to the inner ear, people lose their ability to process sounds and their ability to understand words drops off out of proportion to their ability just to hear isolated sounds. The normal ear has about 16,000 of these hair cells, and they're connected to about 20,000 neurons. So that's a lot of information that's constantly coming in and going out to the inner ear. And it's a two-way street. Your brain is telling the inner ear what you want to listen to, and then your inner ear gives the information back. Another anatomic feature of the cochlea, which is really wonderful for anyone involved with cochlear implantation, is what's called tonotopic organization. So if you look at the turns of the cochlea, the high frequencies are represented down here in the base, and the low frequencies are represented up here at the apex. And that has something to do with the mechanical properties of that basilar membrane, whether it's wide and floppy or whether it's narrow and stiff. And so there's actually a filtering out of sound frequencies within the inner ear that then can stimulate very specific areas or very specific neurons within this cochlear nerve. So it's great for cochlear implant surgeons and cochlear implant recipients, because if we can stimulate these nerves, the sound will be perceived as a high pitch, whereas if we stimulate these nerves at the apex, it'll be perceived as a low pitch. And we'll talk more about why that's important in cochlear implants. So injury to the inner ear usually affects the hair cells, and it usually affects those outer hair cells first. As they die, so do the nerves. The nerves disappear back into the core, and later on, the inner hair cells go as well. And over time, in profound hearing loss, the architecture of that organ of Corti gets lost, and it gets replaced by just a scar band. Right? We'll talk about why that's critical as well. that a lot of the structure actually gets obliterated or lost in ears that have really severe or profound hearing loss. So one of the things we'd like is to regenerate this, right? How can we go from this, where there's no hair cells, to here, where there are hair cells? Of course, just putting hair cells here wouldn't do the trick, right? Not only do we have to have hair cells, they have to be oriented in the right way. They have to be in the right location. They have to have the cells around them that will keep them alive and keep them functional. And you have to have the nerves that then connect to them. Otherwise, if the hair cells are there and there's no nerves connecting it to the brain, they don't do you any good. So it's a multi-step process in inner ear regeneration to go from here to here. Right? But that's a fundamental question that we're asking. And it turns out chickens can do it. Right? And that's a favorite model for this type of research. Birds and reptiles actually do a pretty good job of regenerating their hearing organs. They can take stem cells that are endogenous that live within the inner ear, and when a hair cell is lost, one of those cells can turn into another hair cell, or it can divide and give rise to a hair cell and make another stem cell. Right, so this is the promise, this is the beauty of stem cell approaches to hearing regeneration, because we should be able to unlock that. Somehow between us and chickens, we lost our ability to regenerate our hair cells, whereas they were able to maintain it. But that doesn't mean we can't find some way of unlocking that regenerative capability. And we've got a big lab effort. It's part of the Stanford Initiative to Cure Hearing Loss. It's been going on for years now, and it's led by Tina Stankovic, our department chair, Tony Ritchie, who's in the lab, and Stefan, who leads the lab effort, and Stefan Heller, who's really been the one most focused on this type of approach. And they and their colleagues, and there are quite a few of them, are working on finding ways of getting stem cells from different sources and then eventually regrowing those hair cells that we need to function. Right? And at that point, maybe we could hypothesize that we could give those cells through the blood that would get back to this area, or we could put it in the perilymph, similar to how we would approach a cochlear implant, right? Or maybe even through the endolymph, where the hair cells actually reside, which would be surgical challenges as well. So short of that cellular therapy, are there gene therapies that can be used to induce hair cells to regrow? And the answer is yes. 20 years ago, more than 20 years ago, this was shown to be the case, where if you give a certain gene in an adenovirus package, right? So you put a gene in this adenovirus, put this into an animal's ear that's been deafened, that gene can get into these inner ear cells and induce them to become hair cells. Right, so it's been known that that's been the case for 20 years, and a variation of this was tried in humans. Unfortunately, it didn't turn out to restore hearing like we had all hoped. That said, just this year, and I don't know how many of you have seen this, but it certainly has made quite a splash in scientific and clinical circles. A number of groups at the same time demonstrated gene-based therapy for a subset of children with a genetic hearing loss. And this was published early this year in Lancet. And this is an example from Fudan University in China. But again, there are a lot of different centers, including some here in the United States, that were working on this. And this is to reintroduce what's called otoferlin gene to children who were born without that gene. And if you take this gene and you put it in an adenovirus and you give it to a child that has a profound hearing loss, like these marks here, these arrows show that that child is a 5-year-old girl, she could then hear after 26 weeks. This is phenomenal, right? I mean, not very much makes us this excited about this type of thing. This was the first case of truly restoring hearing in an individual with a genetic defect. Now, we're a long way, unfortunately, from just having this for everybody's hearing loss. This is a very specific gene in a small group of children that does a very specific thing in ears that are otherwise anatomically normal. So this otoferlin gene, and the details of this aren't really that important, but the otoferlin takes those little vesicles that carry the neurotransmitters and allows it to hook on to the membrane and release the neurotransmitters that exist between the hair cells and the nerves. In children with this gene, everything else is okay, except the hair cells don't talk to the nerves, right? So it's a very specific type of regenerative therapy, but it's the first step. It maybe affects maybe 1 to 5% of children with genetic hearing loss, but this is very promising. Right? And my hope is that as we learn more about the different types of genetic hearing loss and we can unlock additional information, this type of therapy is going to be accessible to many more patients. But it's not there for everybody now. And that's why we're still doing electrical stimulation, why we're still doing cochlear implants, and why I still feel good about recommending people who are cochlear implant candidates to go ahead and get a cochlear implant. And we'll talk more about just why that is. But again, my hope is that there will be things that will keep us from having to do as many cochlear implants in the future. So the idea of electrical stimulation has been around for a long time. It was back in the 1700s where Volta took some carbon rods and passed some electrical current on his own ears and said that it sounded like the boiling of soup. Probably not a good idea to try at home, but he was a true explorer and did it anyway and documented the first a report of electrical stimulation of the inner ear. In the 1950s in France, some pioneers used a hand-wound coil and put it into the inner ear, somebody who had no hearing, and that individual was able to hear. And those of us here in California should be proud that there are a lot of the development of cochlear implants is really done here in our state at UC San Francisco, at Stanford, and in Los Angeles at the House Ear Institute. A lot of the pioneering work was done in the 60s, the 70s. And we're very proud of that here at Stanford as well. This is where the first multi-channel cochlear implant was placed. And if there's time, we'll talk more about the surgical approaches, what we're doing with a cochlear implant. But the idea is to put a wire with electrodes into this purple part of the inner ear, which is the scala tympani. And we can get there by going right next to, this is the facial nerve, which is the nerve that moves that side of the face. We put it through the round window, which I talked about being a membrane that's just below the stapes, which is here. And we can thread the wire into the cochlea in that direction to put the electrodes here to stimulate the nerves directly. So there's still, at present, there's still an external component to the cochlear implant, right? A microphone is external and a processor. A lot of people will have just a little button up here where all of this has been integrated into the headpiece. That then communicates with the receiver stimulator, which is under the skin. And there's a wire then that goes through the mastoid into the middle ear, into the inner ear, and stimulates the nerves directly. And I don't have to tell all of you, since you're on Zoom, how important it is for us to all have our hearing connected with our devices. And the interface between implants and other hearing devices and these other phones and smart devices that we use is really critical and needs to be taken into consideration as well for keeping us connected with the world. So cochlear implants were first introduced, or first FDA approved, I should say, in 1984. over that time, they've really been proven to be quite safe compared to so many other things that we do in surgery. They provide environmental awareness in almost all cases. We're pretty good at improving speech in carefully selected patients. We now know that they help with a little bit of hearing in the other side as well, if there's some residual hearing on that side, and you can implant both ears as well. We're still having trouble with hearing in noise, and anybody with a cochlear implant will tell you things that were challenging before they had a cochlear implant are still going to be challenging, but hopefully they're going to do better than they were before. And music, not so great, right? A lot of people have a lot of music appreciation, but not everyone, because we're not capturing all the fine structure of hearing. And unfortunately, we're doing pretty poorly on patient access. It's just about 7% of people that are cochlear implant candidates have actually received them, even though we've now implanted 1 million people worldwide. So what is it that makes some people do well and some people do poorly? There is a wide range of how people do. Certainly the technology has improved considerably. It's just like computer technology. It's changed quite a bit in the last 40 years, right? Our indications for when we say you should receive a cochlear implant or you're a candidate for a cochlear implant have become looser. So we're implanting people with more residual hearing, and as a result, people are doing better. Surprisingly, the cause of the hearing loss is not a big factor as many of us would think, right? As long as there are some nerves to stimulate, there are lots of things that can hurt the inner ear, and it almost doesn't matter what it is that's hurted as long as there are nerves that we have to stimulate. And for whatever reason, different people are wired differently. Some people can make the most of very little information, and some people struggle even when they're given a lot of information. And so the way that the brain processes the sounds is very different between individuals and can really affect how people do with cochlear implant outcomes. And especially for children who are just learning to hear and speak, education and rehabilitation opportunities are really critical, as is the family and support system for our young patients who are learning to develop with these cochlear implants. If you look at the candidacy, and I alluded to this earlier, in 1984, when they were first introduced, you had to be completely deaf. You had to have no auditory information. And over time, we're implanting more and more individuals with more and more hearing. And so the population of patients who are cochlear implant candidates is growing considerably over time. And I think this growth will continue as we do better with our cochlear implant outcomes. And this just shows, the audiogram again, where normal hearing is here. The green is sort of where hearing aids fit in. And the red was cochlear implants when I started doing these back in the 1990s, right? And about 10 years ago, we had cut into that hearing aid category. But now we've got patients we have almost normal low frequency hearing, who have high frequency hearing, who just can't understand words, and we can implant them as well. So we've really moved the bar in terms of where the patients that we're offering cochlear implant technology. So we talked a little bit about some of the patient factors that can affect outcome. I will say that duration of deafness does make a difference. Again, it's more critical with pediatric patients, but even our adults, if you're deaf for 2 years, your nerves are going to be healthier, your brain pathways are going to be healthier than if you're deaf for 20 years or 40 years. Now, that said, we do implant people who have been deaf for decades in an ear, but we have to modify our expectations because the pathways and the nerves that we're going to be stimulating and counting on carrying that information are just not going to be as robust as if they had just been recently deafened. So that speaks to a window of opportunity, especially in our pediatric patients, children who are born deaf. We really try to get them implanted as early as possible so they can make the most of that new information and develop with the sound. This is actually my son when he was born. I can tell you after almost 20 years now that he hears fine. That's not the issue of why he doesn't do what we ask him to do, but he can hear. All children that are born, this was at Stanford, all children that are born get newborn hearing testing before they leave the nursery. This is supposed to happen in 100%, and it's pretty close. It's not perfect, but that way we're picking up children younger that could potentially benefit from cochlear implants, getting them implanted earlier, and they do better that way. We also will get MRI and or CT scans of the inner ear. This is the same patient, the MRI and the CT. We want to see that the anatomy is there that we can stimulate with our devices, right? So here's the inner ear here. You can see this is a cut through the cochlea. This is what it looks like on an MRI. Here are the nerves. Here's the brain. They offer complementary information. We can get the resolution down to seeing individual nerves within that tube that goes between the inner ear and the brain. And here's the cochlear nerve. I know it looks like just a gray smear on the screen. You can see it here. But in some people who don't have hearing, they may not have a nerve, and we have to be very careful about suggesting cochlear implantation in those individuals because there may not be anything to stimulate. Similarly, some people have abnormally shaped cochleas. Instead of having a spiral, right, this is just kind of a blob, a sac. We can implant these people, but that also has to modify our expectation of how people are going to do. So we always have to ask which ear to implant, right? And in general, right, if there are medical reasons why one is better than the other, we will stress that. But otherwise, we pick the ear with the worst residual hearing in the great majority of cases. And that is because we know that better hearing can complement, better hearing in the remaining ear can complement the cochlear implant hearing. Right? So we try to save the better ear for a hearing aid and give people the benefits of acoustic hearing to complement the electrical hearing that we're giving as well. And we implant both sides, a significant percentage of our patients. I think we're probably at about a quarter of our patients have bilateral implants, and it may be higher than that by now. And people can benefit from localization, hearing, and noise. There are lots of benefits if there are candidates. So let's just talk about a couple of illustrative examples of three patients that we implanted. The first is a pediatric candidate, previously healthy, had meningitis. All right, this is an infection around the brain that can get into the inner ears and cause deafness. Right? This is a problem because it can cause the inner ear to scar closed. And if that happens, we lose the ability to put in a cochlear implant effectively. So this patient had some evidence of early signs of fibrosis or scarring in the inner ear. So this child underwent cochlear implantation at age 5 months, which is still the earliest that I've actually put in a device. All right, so that's sort of on one side of the spectrum. And on the other side of the spectrum, are people too old to get a cochlear implant? The answer to that is really no. It's possible to not be healthy enough to have general anesthesia and get a cochlear implant, but age alone is not a factor. And this is a patient who is struggling with her hearing. Her word recognition scores were really horrible. She was becoming socially isolated. So we decided to implant her. She had passed her 100th birthday. And I'd say that this doesn't usually happen, but this patient was remarkable, and she wanted to hear, and she had things to do, and she was volunteering, and we put in a cochlear implant. And last I checked, she was still using it after 5 years. All right, so again, this is an unusual situation, but we have to take every case separately. And here's another patient that we see a lot of. I can hear, I just can't understand, right? It goes back to what I was talking about, and that, people just don't have the kind of clarity with these kind of inner ear problems. And this was her audiogram. Low frequencies in the normal range, but almost nothing in those high frequencies where the consonants are, right? So we were able to implant her right side, and we use techniques that allow us to potentially maintain the acoustic hearing. So these red circles are how she heard without a cochlear implant after the surgery. In many cases, you lose the hearing, the acoustic hearing, right? We got to kind of count on that. But sometimes we're able to preserve that. And this is how she heard with her cochlear implant. So we did a lot of improvement with that and maintained her acoustic hearing. So when she took her hearing aid off, she could still hear. And she was really thrilled with that and came back for her other side as well. And then here's a fourth case, somebody who's 20 years old, lost his hearing suddenly, had problems with horrible ringing in his ear. We don't know why he lost his hearing, but he had no hearing on his left side, normal hearing on his right. 5 or 10 years ago, no way anybody would have considered a cochlear implant for this patient, but now this is routinely done, so we can implant individuals with single-sided deafness, single-sided hearing loss. It takes a lot of coaching because we're not giving normal hearing here, right? And he's got a great hearing on this side. If you add just a little bit of hearing on the left, he may not like it. But understanding what he's going to get, this patient was very happy with it because he was able to localize sounds, hear better in noise, and it also helps the tinnitus, which is another important thing in some of these patients. I see our time is getting pretty short, and I want to make sure that I leave enough time for questions. So I do have a whole set of slides. You know, this is what you get for inviting a surgeon to speak. I'm going to show some at least illustrations of the surgical procedure. If anybody's interested, I'm happy to go through that. But I'd at least like to stop now and see if there's anybody who's got any questions that I can help with.
Dr. Blevins, your remarks were fantastic. I'm sure it's going to generate a few questions, and we'll try to let you go at 2:30 as promised. But maybe people in the audience can just use their raise hand feature. And Dr. Blevins, maybe you can just call on them as they come up.
There's someone from chat, Liz Baker, who has been asking a couple questions.
Yeah, let's see.
All right, I see one here from Ms. Baker. If one has a stapedectomy on the left ear, is she a candidate for a CI? Yes. Either the side that had the stapes surgery or the other side. People with otosclerosis will have mechanical problems like that illustration that I showed, but they'll also have inner ear problems and are often cochlear implant candidates. Sometimes people with otosclerosis will have scarring within the inner ear, so it has to be a cautious or a qualified yes, but I implant a lot of patients that have otosclerosis.
Okay, can you hear me?
Yes.
If they do, I had it done 59 years ago. I had them check it because I needed an MRI of the brain, and they had the records from 1965, but they did not know what kind of wire was implanted. Does that make a difference?
Not for cochlear implantation. There was a small, very small number of implants that were placed that are not MRI compatible. You know, so it's always worth checking on that. I've never seen anybody who's been damaged by that. But the type of wire would not have an impact on the cochlear implantation. Now, 59 years ago, right, it depends on what the hearing was like over those ensuing decades, right, as to whether or not that ear is going to be a good one for electrical stimulation.
Okay, and the other question is, what about Meniere's in the ear?
So yes, so Meniere's disease is a problem that's really characterized by really 4 symptoms, and it's not really a disease. It's a constellation of symptoms, and that's usually fluctuating or progressive hearing loss, ringing in the ear, tinnitus, episodic spinning vertigo, and fullness or pressure in the ear. Over time, that often will become progressively worse and have fewer fluctuations. And when people reach the point where that ear is no longer helpful for them, yes, then they are candidates for cochlear implants. I've got any number of patients that I've implanted who have a history of Meniere's disease.
Yeah,
And sometimes for people who have unremitting vertigo, cochlear implants can help with that as well.
Thank you.
Carolyn, did you have a question?
Yes, I've heard about hidden hearing loss, and I didn't know if there's any connection with cochlear implants or what it is, or if you could just explain.
Yeah, that's a great question. I really don't like the term hidden hearing loss because if you got it, it's not hidden. All right. These are people who really have hearing loss, and it's a difficulty understanding words, usually as a result of noise exposure. That's where it's most commonly seen and where it was described. It's a loss of not initially not the hair cells, but it's a loss of the nerves that plug into the hair cells that carry information from the brain to the hair cells. So it's a loss of the ability to process sounds, and those patients will often have normal thresholds, but decreased ability to hear sounds. And that ability to hear sounds drops off precipitously when there's background noise because it takes more of that active processing. So in general, even though that hidden hearing loss is a problem for people, their hearing loss that's associated with it is usually better managed with hearing aids and with other techniques and cochlear implants because the ability to hear is still better than most of our cochlear implant patients.
Thank you.
Gail Gordon?
Hi, thanks so much for today's presentation. I have bilateral Meniere's, and in the past year, I've had severe hearing loss in one of my ears. You talked a little bit about the healthiness of the nerves. Can you speak a little bit more to that? And also, one of my struggles with my hearing aids is this background noise. It's just so overwhelming that I can't decipher people's voices. I pretty much stopped going out to restaurants, those kinds of things. And you mentioned that that really doesn't change with a cochlear implant. Is there anything on the horizon that's really going to help with that? And why is this such a struggle with all the new technology that we have today?
Yeah,
Thank you.
a couple things on that. First, is that the difficulty with background noise again speaks to the processing of the inner ear. And remember, I was saying those hair cells will contract and actually attenuate the sounds that you don't want to listen to. And it makes your inner ear much more tuned or specific to certain frequencies. And if you take away that processing ability, things sound muddy, and a little bit of background noise will have a much greater effect on your ability to understand words. So that's a very common and a very prevalent complaint that people have, problem that people have when they have some hearing loss. Technology can help with that, things like assistive listening devices, and you've probably been through this where you have a microphone on the person who you're at dinner with, and you have that directly hooked up to your hearing aid. That reduces the signal to noise ratio, which is so important in being able to understand what words are coming through. I'll leave that to Dr. Fitzgerald. He's much better with those types of devices than I am. But I'll also say that there is now a developing area of artificial intelligence processing that's going on where the hearing aids and hearing devices can actually pick up the environment in which you are and in a more intelligent or targeted way, reduce the noise while amplifying the signal. I'm optimistic about that. I think it's something that is yet to be completely proven, but that may help significantly for people who have hearing loss but are not yet cochlear implant candidates. And it may help our cochlear implant patients as well. I will say that hearing in noise is still challenging for cochlear implant patients, but again, depending on how they're doing and how they were doing, they're usually doing better. All right, so that's part of the selection process. And I think the first part of your question was length of time of hearing loss.
Yeah, how do you measure? It sounded like that the healthier the nerves are, the more successful the CI will be. So how do you measure the healthiness of the nerves?
Yeah, unfortunately, we don't have a great way of doing that. And the way that we know is we put it in and we see how they do, right? And there's a lot of unexplained difference, right? It's a pretty wide bell curve of how people do. There's some people who are just incredible, and there's some people who just don't get much from it. And we have to be very careful to pick people who have pre-existing hearing loss so that the majority of people, even on that bell curve, are going to do better than they're doing with their hearing devices. So we really don't know. We don't have a good way of quantifying objectively looking at the health of the nerves and the ability to understand words. I mean, our outcomes, our audiologists are pretty good at that too. They can figure out, who is more likely to benefit from a cochlear implant by talking to them in the real world environments in which they are in and where they're having difficulty. So it's a great question. Unfortunately, we just don't have all the information preoperatively. We just have to sometimes press ahead and see what we get.
Okay, thank you.
There are two
Blevins, it's
in chat.
2:30, and I feel obligated to let you go.
So Elliot, I do have some time. I want to be sure that we address the questions. I appreciate your, and I don't want to hold anybody else.
We have
Well,
the time. We're just
Very
going to
generous of
spend.
you. So maybe if there are more questions, maybe you could stay with us a few more minutes.
There are two more questions in chat.
So in choosing which brand of CI to get, are all three brands implanted in the same manner? So that's from Mr. Miles. There are differences between the devices. I will say that all three companies, all three devices that are currently FDA approved, we offer all of them, and I can honestly tell my patients that they're not going to go wrong in selecting any one of them, right? They approach the way that the arrays are made are different. The processing strategies are different. The external interfaces are different. But people can do very well with any of the three. And we've seen problems with any of the three as well. All three companies have had recalls or damaged devices that break, right? And that's just the nature of these medical devices. So you shouldn't feel like you're choosing the wrong one. There may be a right one for a given individual, but talking with the audiologist and surgeon to help sort that out, I think is going to be the most important. And from a surgical technique, yeah, there are differences. There are differences just because the rays are different, the shapes of the devices are slightly different, but it's really immaterial from my standpoint. I think it depends which box we open for a case. It really doesn't have a big impact on what I do. And am I aware of any developments in external microphones for CIs? Yeah, so I would say over the last 10 years, that's been a major advance in cochlear implants. For a long time, the cochlear implants were just not well interfacing with our phones and our other devices. I think that is changing. I'm sure everybody on the call will be able to tell me more than I can tell you about what that's like with hearing aids or with cochlear implants. I think our audiologists are much happier with the ability to interface with different smart devices, phones, and tablets. I think, I don't know about the Roger microphone. Again, I'll defer to my audiologist to tell you what the options for external microphones are. I will say, one of the things that I think is I had a slide on this, but one of the things that's likely to change in cochlear implant technology in the next 5 to 10 years is we're probably going to be doing totally implantable ones, right? But that having a microphone that's somehow under the skin is a real challenge. And I don't know if I personally would want to be the first one to get those devices. I think that it may be that they're going to work great. And there's some that are being implanted now as part of research protocols. But there are still some technical issues with trying to get the microphones to have the same type of reliability and accuracy as the external microphones do. what determines whether there are any residual hearing after cochlear implant surgery? Yeah, that's another great question. So, I always try to save whatever hearing is left. And if you look at the type of approach that we collectively did, when I started doing this a couple decades ago to what we're doing now, the surgery has become much more delicate once we get into the inner ear. It used to be that we knew we weren't going to save hearing, and so we weren't quite as careful in trying to maintain the inner ear function. We're still not, so that means that, the incision in the inner ear that I've been making probably over the last, 15 years was different from what I did for the first 15 years, right? And sometimes we can save hearing and sometimes we can't. And sometimes it has to do with the amount of hearing that's left in the ear before we do the implant, right? So that patient that I showed you that had almost normal or had normal low tones, we're certainly going to be thinking about hearing preservation more in her than we would in somebody who's got, a standard flat, profound loss on an audiogram. Some ears, for whatever reason, are just more susceptible to hearing loss from cochlear implantation. It probably has to do with scarring or a little bit of bleeding or inflammation in the inner ear. It can happen months, years, or even decades afterwards if there's some scar formation in the inner ear. So just because we save it initially doesn't mean we're going to save it in the long run. And I always try to be very clear with my patients that saving residual hearing can't or shouldn't be the goal through which we would consider success or failure of the operation, right? We do the implant with the idea of the implant and the electrical hearing that we would expect to get from it to have beneficial effects. If we're able to save some hearing, that's great. But I don't want to implant anybody who isn't comfortable with the idea of losing his or her residual hearing, right? And knowing that they're still likely to get better as on the basis of electrical stimulation alone.
One more. Jerry Bergman.
What improvements may lie ahead for implants? Am I destined to just see my audiologist for sulfur? Yeah, so the question is, are you destined to see the audiologist for subtle improvements in program adjustments? I think they're going to be hardware improvements. I think they're going to be software improvements, right? I talked about the hardware improvements, things like a completely implantable hearing aid or hearing device. I think that is on the horizon. It's being put in now. I think there are pharmacologic improvements that are likely to happen. That there can be drug-eluting arrays that provide neural chemicals that cause some of those nerves to grow towards the array and allow it to be more specific, right? That's not going to help people who have an implant in now, right? Because we would have to see a pretty big bump in outcomes before we would say we're going to take out one that's functioning and put in another one with hopes of making it better. That said, there are also software improvements, and I talked about some of this AI processing. I think as that becomes available for hearing aids, it's also going to become available for cochlear implants, right? And to be able to process the sound in real time effectively to really maximize the sound information that's getting in is going to have a big impact on existing cochlear implant users. Now that said, it probably does not get you out of your routine visits with your audiologist. I think you kind of are signed up for that and keep doing that, right? Because even those small, seemingly incremental updates can have a big impact over time. So yeah, don't be too discouraged by that.
Mr. Blevins, this touched upon a question I had, is sort of along the same lines. Most of the advances in technology have come in the processor, either in terms of speech processing or connectivity or what have you. At what point are those advances going to reach the point where you have to upgrade the internal component in order to take advantage of them?
Yeah, that's a great question. And this is always comes up like, do I wait for the next generation of devices, right? None of us are comfortable buying a computer now thinking that it's going to be, useful in 2 years, much less 20 or 25 years. the companies have been pretty good at making sure that advances in processor technology can be retrofit onto older versions of the implanted device. I think that that's been, a commitment that the companies have made to their existing users. And I think that that's good. At some point, those hardware developments are going to outstrip the ability to upgrade the software component. I would say that using today's technology for 5 years or for 10 years, you will still be ahead of not hearing for 5 years or 10 years and using tomorrow's technology, right? And so that's why I really do tell people, if you're a cochlear implant candidate today, there's no reason to wait, because there is a slow decrement of expectations, right? If we keep waiting, and we don't know what's coming up, right? But it's unlikely that there's going to be such a big jump, anytime soon, that it's going to outweigh, what you could be doing by getting up that learning curve with today's technology.
No, that's great. I think Dr. Blevins related to a couple of questions in chat. I meant to tell you or ask you at the beginning that if it's okay to have your permission that we recorded this particular session, which we did before it came online. And what we typically do is make the recordings available to our chapter members who are not able to attend. Are you okay with that?
Yeah.
Wonderful.
I hope it helps.
Yeah, no, this is good. I feel we should really let you go. This was again a wonderful presentation. Certainly the best I've heard on this subject, and we very much appreciate the time you took today to join us.